Good morning, Dr. Stein, and good morning, Nana, and everyone else that would be watching this. My name is Robin Cherian. I'm a final year medical student from KMC Manipal, and I am interested in neurology, and I'm presenting a presentation on the topic of hemicrania continua. Now, I have a personal interest towards headache disorders, and I was fortunate enough to have read about this disorder. And there was a case I've seen in the past of hemicrania continua. So I felt this would be a more apt topic to present. So I'll be starting the presentation now. So the first thing about hemicrania continua is that it's a rare primary headache disorder. Now, the main characteristic features that you should keep a note of is that it's a unilateral continuous headache with exacerbations. And unlike other headache disorders, this has a complete response to indomethacin. In fact, the diagnostic method of uh, choice is a trial of indomethacin versus any other form of testing or imaging. Now, the problem with hemicrania continua is that apart from the fact that it's rare, we believe that it's rather underdiagnosed also, because it mimics other disorders. In fact, it had been confused for cluster headaches. In 1981, it was described by Medina and Diamond for the first time, and they put it under the as a variant of cluster headaches. However, that is not the case, as according to the ICHD3, it comes under trigeminal autonomic cephalagias (TACs), which is completely different, which is not the same thing as being a subtype of a cluster headache. um, Funnily enough, the disorder that it's most confused for during an examination or during a clinical presentation is a cluster headache or a chronic migraine. So, with this presentation, I hope to bring forward some information about this disorder as well as how to diagnose it, uh, a brief idea about its epidemiology, its proposed pathophysiology, and the existing and upcoming treatment strategies. So, we'll start with the epidemiology. Now, this is a primary headache disorder, and it accounts for less than 2% of primary headache disorders, which showcases how rare it is. In fact, it's more commonly seen in women than in men, and it's usually seen in when the patient is in their 40s and in their 50s. Uh, According to literature, it says to the fourth to fifth decade in life, but it is in short, in simple words, it's mainly seen in middle age, in early middle age. uh, Now, the problem about this is, even though the presentation says it's less than 2% of primary headache disorders, most of the time there's diagnostic delay, because a lot of people aren't informed as much of this disorder, which leads to, well, the last point mentioned. The true prevalence might be underestimated, because the main problem with hemicrania continua is the fact that it's fairly underdiagnosed or diagnosed pretty late in its course, when it could have been uh, diagno- uh, diagnosed earlier. Now we will go ahead by talking about the clinical features. Now, this is it's a persistent, it's a continuous headache. It is present throughout the day. There is no waxing and waning. It is not of an episodic nature. As I mentioned in the presentation, there are no pain-free intervals. Now, at times there are periodic exacerbations, and these are usually associated with some autonomic features. Now, the headache is unilateral. It's on one side of the head. Alongside it, ipsilateral autonomic features are seen. Some examples would be lacrimation, rhinorrhea, eyelid swelling, periorbital swelling, and also facial swelling. But facial swelling is fairly rare. Other autonomic features can be seen, but the main ones to keep a note of is rhinorrhea, lacrimation, uh, even ptosis, meiosis can is also seen. Um, now, while literature and the usual presentation states that hemi HC or hemicrania continua is a side fixed headache, there have been case reports of side switching, of cases wherein the headache was present during the course of the disease. It was present on both sides bilaterally, or at one point it would be on the right side, and then it would switch to the left maybe later in the month or later in the week. Now, this is the main clinical features, but one thing that should be also noted is that it shows a complete response to indomethacin. We will get into that when once we talk about the diagnostic criteria. The next thing I would like to touch upon is the pathophysiology. Now, the thing about most headache disorders is that there's always a growing understanding of what could cause, or what is the basis of the disease. However, there is no fixed. There are only ideas as to what are theories that people have postulated about what is the background or the pathophysiology of the disease, and that carries forward for hemicrania continua. So now I've mentioned a few points, and I will elaborate on that regarding its pathophysiology. Now, there is a growing understanding that the trigeminal autonomic reflex arc, uh, an interaction between the trigeminal nerve uh, with autonomic symptoms, is the basis. Now, how this is thought of is that activation of the trigeminal nerve could leads to parasympathetic outflow via the sphenopalatine ganglion. Um, this usually causes typical autonomic features, or autonomic symptoms such as lacrimation, so on and so forth. Now, why is this relevant for hemicrania continua? Is that it's believed that a dysfunction in this reflex arc could be the basis of the ipsilateral autonomic symptoms that coincides with a headache. Now, I've cited a study that was done by Mataru in 2004, and he had published it. Uh, he during in the study they had used functional MRIs to map out what is activated during an attack or an exacerbation of hemicrania continua. Uh, in the patient which they observed during the fMRI, they noticed that the posterior hypothalamus was constantly getting activated. This was a particular finding that interested most people, considering that the posterior hypothalamus has a role in pain control and sensation as well as autonomic function. So the fact that on fMRI they saw that the hypothalamus was getting activated also provided a better idea into the basis of this disease. Now, in like most we believe that because it's related to pain, there is a possible role of inflammatory mediators, particularly cytokines, and they have been noticed in hemicrania patients. A testing of their cerebrospinal fluid shows elevated amounts of some inflammatory cytokines. And now, what makes this relevant is that if it's believed that if the cytokines are constantly present in the bloodstream, these could sensitize uh, the pain pathways, leading to a decreased threshold for pain, which more or less could explain why why hemicrania continua patients have consistent or a continuous headache versus an episodic headache, like migraines or a typical tension headache. This is a continuous headache, and we believe that inflammatory mediators does have a strong role. Now, another thing that shows why inflammatory mediators have a role is the fact that indomethacin aborts an attack or an exacerbation, as well as maintains prophylaxis. The fact that this happens with indomethacin prompted more inquiries looking into the role of inflammation with regard to this headache. And it is also believed that the headache has a basis with prostaglandin mediated pathways, because indomethacin is works on cyclooxygenase, and the fact that indomethacin works provides a clue as to why inflammation, or how inflammation can play a role in the pathophysiology. Now, according to the ICHD3, the most recent criteria for headaches, there is it is diagnosed once it fills a certain set of criteria. The first thing to note is that the headache should be a continuous unilateral headache, and it should be present for more than 3 months, three or equal to or more than 3 months. Now, these headaches are not present from birth. These are not genetic, but they will show up around the time of well, according to the epidemiology, mostly around the fourth or fifth decade of life. So once your continuous unilateral headache is seen for more than 3 months, a thought of hemicrania should be considered in the differential diagnosis. The next criteria is that, along with the exacerbations of the headaches, not the baseline headache, but the exacerbations, they should also show the ipsilateral autonomic features that I had mentioned earlier. The next thing is that a trial of indomethacin uh, should provide some form of response, and only then can we consider strongly that the patient or the presentation is clear for hemicrania continua. Now, while these are more positive findings, we do need to rule out the other anything else that could be in the differential, which is why the fourth criteria is exclusion of secondary causes. Usually, via imaging, uh, they try to rule out other causes that could mimic a hemicrania, or could be a secondary cause, which has been reported in the past. Things to note would be something similar to Budd-Chiari or aneurysms, and maybe other vascular malformations that could cause a headache. So these four criteria are key and crucial to diagnosis of the condition. Moving forward, we we have I have touched upon how this could be a fairly underdiagnosed disorder, and I would like to mention because it mimics other disorders, or maybe we can look at it the other way around. Other disorders mimic hemicrania. Now, the most important one that I would put forward would be cluster headaches and chronic migraine. One way to look at this is that a patient might have a continuous headache, but they might be so used to the baseline headache, or it might not be as significant, that once history taking is done, there might be some form of miscommunication wherein the provider or the doctor would think that the patient only has exacerbations. So they have only noted that there are episodic exacerbations of severe intensity. This usually happens when history taking isn't done, or there is a lack of communication. But why cluster headache is important is that it's often confused for hemicrania and vice versa. Another thing would be chronic migraines. I will touch upon a few of these differentials in the next few slides. Now, cluster headaches. Now, how do we once a differential is made? How do we rule out cluster headaches if the patient is suspected to have hemicrania continua? One thing is there has to be a proper recording of the nature of the headache as well as the duration, because cluster headaches are short episodic attacks. These are usually confused. Hemicrania exacerbations are usually confused for um, as having just short episodic attacks without a note being made for the continuous headache. So during history taking, a note should be made of the nature and duration of the headache. Another thing is that headaches have triggers. One that could be noted would be alcohol, but hemicrania continua does not have a trigger. In fact, it is a continuous headache. Uh, when it came back to we'll go back to the diagnostic criteria, and the third point there was that a trial of indomethacin usually uh, causes a decrease in symptoms, or there would be an immediate response or a response within 24 hours. This would not be the case if the patient had a cluster headache, because indomethacin would not have much effect on cluster headaches. And on a similar note, high flow oxygen that would be given for cluster headaches would not abort an attack, an exacerbation of hemicrania, nor would it cause any form of prophylaxis. There would be no response on high flow oxygen. So these things can help us rule out a cluster headache from hemicrania continua. Another thing that's constantly mistaken, that hemicrania is mistaken for, is a chronic migraine. In fact, patients can go for a few years believing that they have a treatment resistant chronic migraine, when in fact they probably had hemicrania continua. And only after years of trial and errors and treatment pitfalls could that they would they only consider indomethacin, a trial of indomethacin, following which they would recover. This shows that there is a diagnostic delay, which is why once a differential is made, during while taking a case, there should be a consideration of hemicrania continua. Um, Now, the features that would separate both would be that chronic migraines are usually bilateral and throbbing, even though they can be unilateral. But hemicrania continua, barring uh, a few case reports, is usually and by definition unilateral and is a non-throbbing headache. Another point is that hemicrania continua has virtually no aura features, such as floaters, and they also don't have migrainous features such as photophobia, phonophobia, which would be present in a patient of chronic migraine. The fact if a patient presents or states that they have aura-like features, then that should rule out hemicrania continua. But if there aren't any aura-like features in a patient that hasn't been have responsive to typical treatments for migraine, such as CGRP inhibitors or triptans, hemicrania, a trial of indomethacin should be done to at least rule out hemicrania continua. Now, hemicrania also has continuous pain. Chronic migraine has typical migraine attacks. Even though they do last a day, they are specific migraine days, which, again, when taking a note of the nature and duration of the headache, you could discern whether the patient has a migraine versus could this be hemicrania continua. And as it's has been mentioned, indomethacin will have no effect also on chronic migraines. Another disorder that was I've mentioned in the differential diagnosis is new daily persistent headaches. Now, this disorder is usually a diagnosis of exclusion. Now, it's usually triggered by is usually abrupt onset, and it's triggered by an event. Now, it's usually seen in post-viral illnesses. So a new daily persistent headache is similar to hemicrania in the fact that it is continuous, but there is also an understanding that this has an abrupt onset, and there is also an associated history of an event triggering it, which is not seen in hemicrania. Now, another key distinction that can be made is that there are no autonomic features in new daily persistent headaches, whereas in hemicrania continua, this virtually is there all the time during an exacerbation. This is not present during the continuous headache, but when the headaches, when they increase or an exacerbation happens, you would see ipsilateral autonomic features. Based on the pain localization, hemicrania, again, as I've mentioned earlier, is strictly unilateral, uh, which should help in the diagnosis of hemicrania versus newly NDPH, which can be bilateral or generalized. And NDPH does not respond to indomethacin. So if a trial of indomethacin is given for a day, and there is no response, then it's most probably not hemicrania, and it could we could consider new daily persistent headaches in the diagnosis. I would like to note that since it is a diagnosis of exclusion, uh, it only makes sense to consider it as strongly for a diagnosis only after ruling out hemicrania continua. Now, there are other causes, other mimics, and something that could be seen in the differential diagnosis. Some that I've touched upon in the previous slide would include something like trigeminal neuralgia, which has pain in the distribution of the trigeminal nerve and is usually unilateral, but again would vary in presentation from HC. Secondary conditions that might mimic hemicrania, apart from uh, other primary headaches or arthritis, temporal cell arthritis, could include post-traumatic headaches, post-stroke headaches, a space-occupying lesion or a mass in the brain or in the skull, and aneurysms at dissections. These have to be ruled out by in if hemicrania is considered, these have to be ruled out via imaging. So if we are considering that a patient or a case could could strongly have hemicrania continua, exclusion of other disorders have to be made first, because it wouldn't make sense to strongly uh, make that diagnosis without ruling out the other causes which can mimic a hemicrania headache. Now, we will now touch upon the treatment. We have seen the pathophysiology of the disorder, the postulated theories as well as hypothesis. We have touched upon clinical features as well as the diagnostic criteria outlined by the ICHD. We have also talked about other things in the differential diagnosis when we are considering this, so we can rule other causes out before we make a diagnosis of hemicrania. Now, once all of this has been accounted for and a diagnosis of hemicrania is made, uh, we have to look now in terms of treatment. Now, because trial of indomethacin is used in the diagnosis, it provides a hint in saying that it is also the treatment of choice. In fact, it does two things at once. It essentially it hits two birds with one stone. Indomethacin is usually given for as a trial when they want to consider hemicrania continua in the diagnosis, and usually it shows an immediate response, usually within 24 hours. But there have been reported instances when it has extended beyond 24 hours. But there has to be a response. There has to be a decrease in headache symptoms, and once that has been that's observed by the doctor and uh, the patient is prescribed indomethacin long term for the treatment. A typical dosage would be 25 milligrams thrice a day, and depending on need, it can be increased. But there are small problems associated with the treatment of hemicrania. Whilst it does sound uh, nice that a patient can be diagnosed with the medicine and can finally be relieved of pain with 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 something that seems like a one-stop solution, the problem is that indomethacin can have toxic side effects on a patient. Now, indomethacin is used for both exacerbation as well as long-term prophylaxis. So when we look at the long-term care, a note should be mentioned that there should be an effort keeping it at the most minimal dose as much as possible because of the side effects that we will touch upon henceforth. Uh, they have gastrointestinal side effects, which makes long term use a little bit difficult. But why does indomethacin work? Now, we have touched upon that in the previous slide on the pathophysiology, wherein inflammation has a significant role in the in the backbone of the disorder. And indomethacin also is most effective because it has a very good CNS blood brain barrier penetrability, which makes it much better than any other uh, NSAID. It also works on both cyclooxygenase 1 and 2, which makes it more broad spectrum, and hence it's an appropriate drug, and it does make sense why indomethacin works for this disorder. Um, but considering that indomethacin has long-term toxic effects, there has to be more effort looking for alternatives, and certain studies have been done to look for alternatives in patients that cannot tolerate the indomethacin long term or have shown resistance or intolerance to indomethacin. Certain cyclooxygenase 2 inhibitors like meloxicam and celecoxib have shown some form of efficacy in the treatment of hemicrania continua. Other medications as an alternative include gabapentin and topiramate, which help in moderating the pain, but it doesn't really have a much efficacy as compared to indomethacin. But the fact that it does have some form of pain relief or pain modulation uh, does warrant its addition in the management, at least as an alternative treatment option. Now, a study has been done by Garate, and that was published in 2022, which show that a certain CGRP inhibitor. Now, CGRP inhibitors are mainly used for migraine disorders, uh, but this study showed that there has some form of efficacy with a CGRP inhibitor with hemicrania continua. CGRP inhibitors are fairly a more novel way of approaching migraine disorders, and if it does have some form in pain relief here, in for a headache relief in hemicrania continua, that would prove to be most beneficial, considering that indomethacin has long term side effects. So these are medical ways of managing the disorder using drugs, but there are other forms of treatment uh, that have been seen in trials uh, that involve procedures. One was vagal nerve stimulation, and this was done by Erin O et al. And published in in Headache in 2017. Uh, how vagal nerve stimulators could help with the treatment of this disorder would be that vagal nerve stimulators are uh, m- the vagal nerve is, now we'll go back in terms of neuroanatomy. The vagal nerve will be connected to the nucleus tractus solitarius, which again goes to which also has two connections to the periaqueductal gray and the locus ceruleus, both have having roles in pain and pain modulation in the body. Whilst these are proposed connections, there isn't for 100% concrete evidence that vagal nerve stimulation would completely help, but based on the study, it showed that the patient had some beneficial effect, which could possibly link at cementing a relationship with vagal nerve stimulators as well as pain control. But this is a new approach and something that could be looked forward to in the future in terms of more trials and um, more literature review. Another thing is deep brain stimulation. Now, Leone et al. In 2010 published a report wherein they used deep brain stimulation to uh, alleviate the pain in a patient of hemicrania continua. What they noted in this study is that they focused mainly on the posterior hypothalamus. Um, Earlier in the pathophysiology discussion, and the study done by Mataru et al. Showed that the posterior hypothalamus is usually activated in a lot more in patients of hemicrania continua, and this was done using the fMRI. On that basis, a consideration was made that deep brain stimulation, specifically to the posterior hypothalamus or within that region, could alleviate pain, and the results of that study showed that it did have a beneficial effect on a patient of hemicrania continua. This is also another way of looking at treatment apart from typical of in indomethacin or a typical drug regimen. This provides more options, and this is something that people should look in researching, which and providing a novel way of approaching or treating the disorder. Botulinum atoxin also could have an effect, and there have been limited studies showcasing its efficacy, but it's something that could be considered, considering its use in migraine disorders. Nerve blocks is another procedure that have been considered in the treatment of hemicrania continua. Now, a study was done in the journal Revista de Neurologia in 2012, and it was a clinical study in 36 patients where they provided nerve blocks in either supraorbital trochlear injections of steroids, or in the greater occipital nerve. And they 53.6% of patients showed uh, almost complete relief, and 32 approximately 30% of patients showed minimal relief. Now, whilst the studies seem fairly significant, the effects of these nerve blocks are temporary and uh, won't have much, which shows that nerve blocks won't have much use for a long term um, prophylaxis of the disorder, but definitely is something to be considered, especially with regard to the exacerbations or another form of treating the disorder, mm, apart from indomethacin. Because here's one thing that should be noted: the current treatment regimen for hemicrania continua is mostly is indomethacin. Whilst it sounds good having a one-stop solution, it is it is much better to have a wide variety of ways of approaching or treating the disorder, which provides options to the patients as well as limits the side effects that are associated with indomethacin. Now, I will go to the next slide, which talks about complications of this disorder. Now, unlike other disorders, the complications associated with hemicrania continua is mainly regarding its treatment. I have mentioned this time and again in this presentation, that indomethacin on long-term use has various side adverse effects. It's not limited to gastrointestinal upset, nausea, vomiting. Patients can develop hypertension and renal failure. And this is mainly seen when patients take indomethacin for long-term use, and that's a hallmark in patients of this disorder, considering that is the primary mainstay, the primary mode of treatment. So the main complication regarding with the disorder is related to indomethacin, and hence, uh, when indomethacin is prescribed, follow-ups are required to ensure not only compliance with or not only continuity of care or continuation of the treatment, but also to ensure that the patient is doing well, considering the serious adverse effects it can pose, as well as other prescriptions can be made to counteract some of the side effects, such as nausea and vomiting, by providing antiemetics and other drugs to combat this. But follow-ups are very much required, considering the treatment of choice is indomethacin. Uh, we have touched upon a lot of things in this presentation of hemicrania continua, starting from its diagnostic criteria and pathophysiology to its common clinical features. We've looked at varied, how variable disorders can be confused for hemicrania, and how hemicrania continua tends to be, or can suffer patients can suffer from diagnostic delays due to the differential diagnosis. And we also looked into various novel treatments and management, apart from the gold standard treatment for it, which is in indomethacin. And it I would like to conclude this presentation by saying that This is a fairly misunderstood disorder and something that most neurologists and headache specialists tend to overlook. But and a little more focus could be made in that when we try to diagnose various primary headaches, considering this could fall under diagnostic delays. And the best thing about hemicrania continua is that it is treatable, even though as I've mentioned, the medication has various untoward effects on the patient. A good understanding of the of the differential diagnosis is crucial, because through history taking only, a, a good idea of whether a patient has this disorder versus whether they have something else can be made. A strong focus on the duration of the headache and the type of the headache, as well as an extensive uh, history questioning can be made about the headache, and that only can help discern whether the patient is likely having another primary headache disorder or is having hemicrania continua. The various therapies that I've mentioned, from vagal nerve stimulation to nerve blocks, provide much hope for these patients. In terms of other alternative therapies, is something that we could be looking forward to in the future, for the patients of this disorder, as well as look seeing the future of headache medicine. Hopefully, uh, with a better understanding of this disorder of hemicrania continua, better forms of management as well as better treatment of the patients who are suffering from the disorder can be made. Um, I hope this presentation was fruitful and informative, and a good picture of hemicrania continua is there for all those of y'all who are listening onto this. Um, I'd like to conclude by saying thank you, and I hope this was a good presentation. Yeah.
Good.
Good job.
Start off. We do that. Yeah, okay. Stop recording. Okay. Very good.